Have you ever really stopped to consider the architectural marvel that just sits right in the middle of your face, like the human nose, the tip specifically?
Yeah, people really don't think about it structurally.
No, they don't. We have this tendency to think of it like, I don't know, a block of clay, right? Just something that a plastic surgeon kind of molds and squishes into a new shape.
Right, like sculpting.
Exactly. But it is not clay at all. It is this incredibly complex, tension-bearing structure made of skin, soft tissue, and these highly specific intersecting arches of cartilage.
It's essentially a biological suspension bridge.
A suspension bridge. I love that.
Well, it is. If you remove the wrong strut, or cut a wire that's bearing too much load, the entire structure can gradually collapse under its own weight, or even just under the tension of healing tissue.
And that actually brings us to our mission for today's deep dive. We are jumping into this truly fascinating medical text from the Open Access Atlas of Otolaryngology, Head and Neck Operative Surgery.
It's a fantastic, incredibly detailed resource.
Oh, it really is. We're looking at a specific chapter authored by Dr. Gilbert Nulse-Trinité, which focuses on the basic approaches and techniques in nasal tip surgery, or rhinoplasty.
Right.
So for anyone listening, whether you are a medical student, maybe considering a procedure, or just fascinated by anatomy, we are going to demystify this highly technical, high-stakes world of facial engineering.
It's a vital text to study because, as the author notes right at the beginning, the historical medical literature surrounding nasal tip surgery has been, well, incredibly chaotic.
Chaotic how? Like just disorganized.
Think about it. There are virtually endless individual differences in human anatomy, right? And that's compounded by a vast array of competing surgical opinions over decades.
Oh, that makes sense.
Yeah, before modern standardization, techniques often relied heavily on just aggressive removal of tissue, cut it out to make it smaller. But a pioneer in the field named Tardy completely changed the paradigm.
Tardy.
Yes. He advocated for a highly systematic, rational approach focused on preservation rather than just excision.
And that systematic framework is basically our roadmap for today. But before we get into the actual physical mechanics of the surgery, we need to establish the core philosophy of this text, the absolute golden rule.
The do no harm baseline.
Exactly. The primary goal for any nasal surgeon isn't just about making the nose look good the minute the patient wakes up from anesthesia. The true secret to good long-term post-operative results is to operate as atraumatically as possible and to preserve tip support.
What's really fascinating here is the emphasis on the fourth dimension. Time.
Time, like ages.
Biological forces, yeah. Like gravity and scar tissue, they are relentless. Scar tissue doesn't just sit there. As it matures over months and years, it undergoes contraction.
Meaning it literally shrinks and pulls.
It shrinks and pulls. So if a surgeon goes in and aggressively removes the cartilage scaffolding just to get an immediate, dramatically smaller aesthetic result, I mean, that nose might look fine for 6 months.
But 5 years down the line.
Exactly. 5 years down the line, that shrinking scar tissue will overpower the weakened scaffolding. You start to see drooping, severe pinching, or just total structural failure.
Wow.
That's why the do no harm principle is the foundation of everything we're about to discuss. It's about predicting the biomechanics of the healing process over an entire lifetime.
Okay, so let's unpack this. The text breaks down the surgical approaches into a sliding scale of intervention, starting with the least invasive, which is the non-delivery approach.
Right, the most conservative option.
When I was reading the mechanics of this, the best analogy I could come up with is that it's like doing a full kitchen renovation on a house, but you are only allowed to pass your tools and materials through an open window.
That is actually a perfect analogy.
You are not taking down any exterior walls.
Right, you're working strictly from the inside out, operating entirely through the nostrils in this confined, dark space, without ever pulling the structural components out into the open to actually look at them.
Which sounds incredibly difficult. So what is this used for?
Well, because it's so restricted. This non-delivery approach is specifically indicated for relatively minor adjustments. We are talking about small volume reductions of the lateral crust.
Which is the main sweep of cartilage that shapes the outer curve of your nostril, right?
Exactly. Or, a slight cephalic rotation of the nasal tip.
Cephalic simply meaning pointing toward the head, so a slight upward rotation or lift.
Right.
But wait, if they're practically flying blind in the non-delivery approach, how on earth do they ensure they aren't accidentally cutting away the structural support? I mean, it sounds like trying to cut a single load-bearing wire in the dark.
It is the exact challenge. But the surgeon isn't totally blind. They rely on an incredibly strict system of topographical mapping to safely execute what the text calls the cartilage splitting approach.
Topographical mapping inside a nostril, how does that even work?
The surgeon takes a rigid surgical instrument like the back of a scalpel handle or a suction tube and physically presses it against the inside of the nose, the vestibular skin.
Oh, I see.
Yeah, by pressing upward against the cartilage, they create a temporary physical imprint or crease. That imprint becomes their visible guide map for where to make the internal incision.
That makes so much more sense. But here's the structural rule that really caught my attention. The text is incredibly rigid about this.
The 5 millimeter rule.
Yes. When the surgeon is cutting away the upper part of that lateral cartilage to reduce the volume, they must preserve at least 5 millimeters of uninterrupted cartilage vertically. Just 5 millimeters.
It sounds incredibly small.
It does. Yet it is the critical difference between a nose that holds its shape and one that caves in.
It highlights the extreme tensile strength of cartilage, but also its absolute breaking point. Those 5 millimeters represent the absolute minimum biological load-bearing threshold needed to fight the forces we talked about earlier.
Gravity and the scar tissue.
Right. It has to resist the downward pull of gravity, the inward vacuum pressure generated every single time you take a deep breath, and that slow tightening of scar tissue. If a surgeon gets overzealous and cuts that continuous strip down to, say, 3 millimeters, the cartilage will almost certainly buckle during the healing phase.
It really makes you appreciate the micro-precision required here. And to actually get that targeted piece of cartilage out, the text outlines a really meticulous two-stage process.
Yes, you can't just hack away at it.
Exactly. Instead of taking a scalpel and slicing through the inside skin and the cartilage all at once in one big chop, this approach advises using a number 15 blade. That's a very small, precisely curved blade, perfect for tight spaces.
Very standard in plastic surgery.
Right. So they use it to first incise just the vestibular skin. Then you use sharp, curved scissors to carefully dissect that skin away from the cartilage underneath. And only after separating those layers do you split and remove the targeted piece of cartilage.
And there's a good reason for that. By separating the layers first, you maintain absolute control over the depth of your trauma. You aren't blindly hacking through distinct anatomical structures.
Because that vestibular skin lining the inside of the nose is incredibly thin and delicate.
Exactly. If you slice through it recklessly along with the cartilage, you invite thick, irregular scarring right where the airway needs to be incredibly smooth.
Which would be terrible for breathing.
Right. Once the cartilage is carefully removed, everything is meticulously stitched back together with 5-0 atraumatic suture material.
The 5-0 meaning a thread that is exceptionally fine, right?
Basically the thickness of a human hair. It's designed to glide through tissue without tearing it.
Got it. Now the text does briefly mention another non-delivery method called a retrograde aversion technique, where they dissect backward over the cartilage, but it specifically notes this is performed less often these days.
Yeah, the cartilage splitting technique is really the star of the show for minor tweaks.
Right.
If we connect this to the bigger picture, the non-delivery approach remains the gold standard for straightforward cases, for one simple reason. It leaves the overall continuous arch of the lower lateral cartilage completely intact.
Because by working entirely through a tiny internal slit, the connective tissue network is barely disturbed.
Exactly. The body generates far less unpredictable scar tissue, ensuring a really uncomplicated healing process.
But what happens when the house needs more than just a minor window renovation? Like what if a patient comes in with a bifid tip?
Oh, right.
You know, a tip with a deep, highly visible cleft or split right in the middle, or severe asymmetry, or what the text quite literally refers to as a highly overprojected Pinocchio nose.
Yeah, tiny internal trim isn't going to fix fundamental architectural flaws like those. No. That is precisely where the surgeon must escalate the level of intervention and move to the delivery approach.
The delivery approach. It sounds a bit intense, and honestly, the mechanics definitely match the name. This is more traumatic to the surrounding tissues, but it solves the surgeon's biggest problem, visibility.
Right, they need to see the entire structural framework to reshape it.
So to achieve that visibility without completely flaying the nose open, the surgeon creates a specific set of internal incisions that allow them to detach the cartilage from its surrounding tissue and physically pull it out of the nostril to work on it.
Think of it like pulling a drawer entirely out of a cabinet so you can repair the tracks on the side.
Pulling the drawer out. To do this, they make two distinct cuts. First, an intercartilaginous incision. The text notes this must be made caudal to the nasal valve area. Caudal just means toward the pale or the bottom end of the nose.
And this specific placement is crucial. It prevents scarring in the internal nasal valve, which is the narrowest part of your airway. If you scar that valve, the patient might look great, but they'll struggle to breathe forever.
Yeah, definitely a bad outcome. But the second cut is the one that really fascinated me. It's called the marginal incision.
The marginal incision is an absolute high wire act for the surgeon.
The text practically issues a warning label for it. The incision has to tightly trace the very bottom edge of the lower lateral cartilage. Why? To avoid damaging a tiny critical anatomical feature called the soft triangle.
The soft triangle, yeah.
When I was reading about the soft triangle, I instantly pictured a vital, load-bearing pillar in the middle of a room. You just do not touch that pillar.
That's a great visual. The soft triangle is a delicate, very thin area of skin situated right near the upper rim of the nostril opening. What makes it so vulnerable is that it has absolutely no underlying cartilage to support it.
Wow, none.
None. It's just two layers of skin with some soft tissue in between. If a surgeon's scalpel strays even a millimeter and accidentally cuts into that soft triangle, the resulting scar tissue contracture will pull the skin upward.
Oh, yikes.
Yeah, it causes a highly visible permanent notch in the rim of the nostril that is notoriously difficult to reconstruct. So tracing that cartilage edge perfectly is mandatory.
Here's where it gets really interesting. Once those two incisions are made, the surgeon uses small, specialized tools to free the cartilage from the soft tissue skin envelope above it. Right. Then they create what the text calls bipedicled chondrocutaneous flaps. Let's translate that. Bipedicled means the tissue stays attached at two ends. You don't sever it completely, which ensures continuous blood supply so the tissue doesn't die.
Crucial for healing.
Exactly. And chondrocutaneous simply means the flap consists of the cartilage itself, the chondro, and the thin inner lining of skin, the cutaneous. They literally deliver these attached flaps down and out through the nostril opening.
And the surgeon is now looking directly at the architectural arches of the nasal tip.
Right. And because they can finally see the entire structure in 3 dimensions, their surgical toolkit dramatically expands. They're no longer limited to just trimming. They can actively re-engineer the shape.
Which is a game changer.
It is. Let's talk about that toolkit. If a patient has a bulging convex cartilage that makes the tip of the nose look wide or bulbous, the text mentions techniques called scoring or morselization. But why crush or score it instead of just cutting the bulge out entirely?
Because, as we established, cartilage is living tissue with an ingrained structural memory.
Right.
It is woven with microscopic, interlocked collagen fibers. If you just bend a piece of cartilage, those fibers will act like a spring and eventually snap it back to its original shape.
So you have to break the spring.
Exactly. Morselization involves using a specialized crushing instrument to gently crush the cartilage matrix. It physically breaks those microfibers just enough to destroy its memory, turning a stiff, bulging arch into a softer, pliable ribbon that can be molded into a refined shape.
Or consider the beefed tip with the deep cleft we mentioned earlier. Because the cartilage arches are exposed outside the nostril, the surgeon can use a very specific stitching technique called a horizontal mattress suture.
This is a crucial mechanical detail. A standard medical stitch is a simple loop.
Right.
But if cartilage is under tension, a simple loop can act like a cheese wire, slowly slicing through the delicate tissue. A horizontal mattress suture works differently.
How so?
The needle goes in, travels horizontally through the tissue, comes out, and then loops back parallel to the first pass.
Oh, I see. It creates a square of thread that distributes the pulling force over a much wider surface area, like pulling a drawstring bag closed without ripping the fabric.
Exactly. They use a non-absorbable thread like Gore-Tex or a slow-absorbing one called PDS, polydioxanone.
PDS holds the cartilage domes tightly together for months, just long enough for permanent scar tissue to form its own natural bond, and then it safely dissolves.
Brilliant engineering.
Truly. Now, the most dramatic maneuver in the delivery approach seems to be reserved for the pension nose, or that overprojected nose. To bring the tip closer to the face, the surgeon might utilize the interrupted strip technique.
Right.
They literally cut the continuous arch of cartilage completely in half, remove a segment, and stitch the shortened pieces back together. They are purposefully breaking the continuous suspension bridge to shrink its total span.
Which actually brings us to the fundamental trade-off of the delivery approach. When you sever the continuity of that cartilage arch, you are playing with fire.
Yeah, the text issues a strong caveat here.
Cutting straight through the cartilage creates a very real risk of unpredictable biomechanical healing. As those severed ends try to fuse back together surrounded by contracting scar tissue, they can buckle, warp, or even overlap.
And if the patient happens to have thin skin, every single one of those microscopic internal healing irregularities is going to telegraph through. It will show up as a visible, unnatural bump or sharp dent on the outside of their nose months after the surgery.
To camouflage this risk, the text mentions surgeons will frequently use an on-lay tip graft.
Okay, what is that?
They take a small, smoothly carved piece of cartilage, often harvested from the patient's own septum deeper inside the nose, and physically lay it over the surgically altered area.
Oh, like throwing a thick, smooth blanket over a lumpy mattress to hide the springs.
That's a great way to put it. But the overarching lesson remains clear. The delivery approach offers excellent visibility, but because you are detaching and manipulating so much tissue, the long-term healing is fundamentally less predictable than the window renovation of the non-delivery approach.
Okay, I have to challenge this whole progression though. If visibility is so vital for complex work, and the delivery approach still requires the surgeon to wrestle these flaps out of a tiny nostril opening while risking warped healing, why don't surgeons just open the nose up completely every time so they can see exactly what they're doing without fighting the anatomy?
Well, you've just described the nuclear option of rhinoplasty, the external approach.
And the mechanics of it are intense. If the non-delivery approach is renovating through a window, and the delivery approach is pulling a drawer out, the external approach is taking the roof entirely off the house so you can stand inside it.
It provides the absolute ultimate unencumbered exposure. By lifting the entire skin envelope off the nasal framework, the surgeon can see the anatomy in its natural resting 3D position without the distortion of pulling it through a nostril.
Which is a huge advantage.
It is. And most importantly, it allows for true bimanual surgery. The surgeon can use both hands simultaneously to manipulate grafts, tie complex sutures, and execute structural engineering that is physically impossible to do with one hand through a nostril.
To get that kind of access, the surgeon has to make what's called a mid-columellar skin incision. The columella is that little vertical strip of skin and tissue right between your two nostrils.
Right.
They literally cut across that strip, connect that cut to the internal incisions, and peel the skin upward toward the forehead. But with unprecedented access comes unprecedented risk.
Significant biological risk.
Yeah.
The columella is a highly delicate structure. When a surgeon is cutting and preparing that skin flap to lift it, they must be incredibly careful not to injure the medial crura beneath it.
The medial crura are the two parallel strips of cartilage running right up the center of the columella, essentially acting as the central tent pole for the entire nasal tip.
Exactly. If you accidentally sever or damage that tent pole while peeling the skin back, you instantly lose your primary center of support.
And closing that external incision isn't just a matter of slapping a butterfly bandage on it either. The text places huge emphasis on the meticulous suturing of that mid-columellar cut using a microscopic 6-0 nylon thread.
Because if the edges aren't aligned perfectly, or the stitches are too tight, the tissue can suffer from necrosis.
Because the blood supply has been disrupted.
Yes, the tissue literally dies from lack of oxygen, leaving the patient with a gaping wound or a highly visible jagged scar right in the dead center of their face.
This raises an important question, and it's a controversy the text addresses head on. The external approach is undeniably easier for the surgeon in terms of visibility. It completely takes the guesswork out of the equation.
Yes, it does.
Because of that ease, the text explicitly warns about a dangerous tendency, particularly among less experienced surgeons, to use the external approach routinely for every single patient simply because it makes their job easier in the operating room.
It's the classic, when you have a hammer, everything looks like a nail problem. The surgeon must constantly weigh the severe surgical trauma of completely unroofing the nose, disrupting all those microscopic blood vessels and lymphatics against the required results.
You do not use a sledgehammer to hang a lightweight picture frame.
Exactly. The external approach is truly indicated for extreme, highly complex cases where the the underlying architecture is either destroyed or entirely missing.
And the text provides some incredible clinical examples to ground this concept. One case study involved a patient with a congenital deformity known as total agenesis of the nasal bones.
Agenesis means they were literally born without them.
Right. They had no bony bridge, combined with a highly overdeveloped extreme trapezoid-shaped tip. You simply cannot build a bridge through a nostril.
Oh, you can't.
The external approach was mandatory, so the surgeon could use both hands to perform complex intradermal suturing to bring the tip together, execute the interrupted strip technique, and even cut wedges of tissue out of the base of the nostrils to stop them from flaring out.
The complexity of a reconstruction like that is staggering. You aren't just tweaking existing anatomy, you're essentially building a freestanding biomechanical structure from scratch.
Another powerful example was a patient with a bulbous tip that severely lacked projection, meaning the tip was far too close to the face, giving a flattened appearance. The surgeon utilized the external approach so they could access the septum deep inside the nose, cleanly harvest a strong, straight piece of cartilage, and use it to build a rigid columella strut.
A columella strut is fascinating. It acts precisely like a steel I-beam anchored to the bony base of the face. It runs up between those medial crura we talked about to provide massive, rigid support.
Exactly. They combine that steel I-beam with a shield graft placed flat on the tip to physically push the thick skin envelope outward and force definition into the tip. They were literally doing structural engineering, adding beams and shields to fight the heavy downward weight of the skin.
And you simply cannot achieve that level of millimeter-perfect architectural grafting, securing a strut to the facial base while balancing a shield graft on top, without the full, unencumbered view provided by the external approach.
But the trade-off is immense.
The trauma to the tissue is massive, and the postoperative swelling will take significantly longer, often over a year, to fully resolve compared to the internal approaches.
So what does this all mean? When you look at this medical text in its totality, you realize that nasal tip surgery is fundamentally a sliding scale of visibility versus trauma.
It really is.
From the incredibly delicate hidden incisions of the non-delivery window approach, to pulling the cartilage drawer out in the delivery approach, all the way to taking the roof off with the external approach. The surgeon is always playing a high-stakes biological game of structural Jenga.
It is a constant real-time calculation in the operating room. The surgeon must always ask, how much access do I absolutely need to fix the specific problem, versus how much natural structural integrity am I willing to permanently compromise to get that access?
It completely reframes how you view a successful rhinoplasty. It is so much more than a surface-level cosmetic alteration. It's an exercise in physics.
It truly is. And I think that leads us with a final thought to ponder as we wrap up. We culturally tend to think of plastic surgery purely in terms of aesthetic addition or subtraction.
Sculpting that block of clay until it looks perfect under the bright lights of the operating table.
Exactly. But based on the rigorous philosophy outlined in this text, the true, enduring mastery of rhinoplasty lies in invisible preventative engineering.
The most crucial part of the surgery isn't necessarily the tissue that the surgeon bravely cuts away.
No, it is those microscopic millimeters of cartilage they deliberately, carefully leave behind in the dark, so the nose can wage a lifelong, silent war against the relentless pull of gravity and the slow contraction of scar tissue.
The genius isn't just in creating a beautiful new shape, it's in engineering the unseen suspension bridge so it never, ever falls down. Keep that invisible architecture in mind the next time you look in the mirror.